The first one was a clinical pharmacology session that involved the two new and expensive drugs, Entresto and the PCSK9s. And the question was, of course, who should get these, and how good were they, and were the, even sort of early on in their trials, are they good enough that we should be using them a lot? And also, were they cost effective? Because, for example, the PCSK9s are $14,000 a year, and Entresto is about $5,000 a year. So that's a lot of money compared to the generic drugs that are a few $100s a year. I think most of what I heard was these drugs look like they are going to be an improvement, but that it'll be a selection process. Not everybody needs these drugs, we'll see also with time. There's a professor that sort of tongue-in-cheek when I was in school used to say, new drug comes out, use it quick before we discover all the problems. And of course we've seen that. For example, the statins were a good example. They came out, the trial said 0 side effects, and it's amazing, and it is true. They markedly reduced mortality, but we're now seeing a fair number of side effects and other issues with the statins that weren't recognized initially. I think Entresto is going to stay with us to stay, but it's a double vasodilator, so hypotension was a problem with it, and the expense is a problem. I think what I came out of that with, if my patient's doing fine, asymptomatic or minimally symptomatic on standard evidence-based medicines, I'm not going to start the new drug. The patient that's having problems, recurrent edema, recurrent shortness of breath, the standard drugs aren't working as well as they ought to, I think that's a time to try that. Same thing with the new cholesterol blockers. I think they are very remarkable in their ability to lower cholesterol, but they're very expensive. So again, I think you're going to be using them more for people who fail on statins, or who have terrible side effects on statins, or who have familial hypercholesterolemia, which is not that common. Those are folks with really staggeringly high values of cholesterol, and they don't respond adequately to statin therapy. And we'll see. It's going to be a few years. We'll get some market, some market experience, some big databases, and also there's a number of trials that are going to look at longer term outcomes with these drugs, and so we'll get better informed, but they look like some good agents to start with. If the cost were exactly the same, I would still be a little slower. I'm a little, I've just written an editorial for the Green Journal that said, there was this famous quote about, if you're not a liberal when you're young, you have no heart, and if you're not a conservative when you're old, you have no brains. And so I've become more conservative in my medical, sort of interventions. If I have a patient that's doing well on a statin, that's costing, $10 for 3 months, and they're perfectly stable and happy and so forth, I wouldn't necessarily jump to the new drug. Now, what might change my mind is, there's this huge debate about should we treat patients and keep following their LDL cholesterol and get them down to a certain level, or should we just decide, hey, this patient's high risk, just treat them aggressively, or this patient's very low risk, let's not treat them. And there's a fight, in fact, there's a transatlantic fight with the Europeans arguing for get to goal, get the LDL down to 60 or 70, and the most recent American AHA-ACC guidelines saying treat based on risk. So we'll get some information out of these new studies because the PCSK9s are going to knock the cholesterol way down. And then we'll see, do we get more bang for the buck with that? If we do, then I think a lot of us are going to have a tendency, to push harder on using the PCSK9s. They're injectable. Most patients don't like to inject themselves. Now they have these injector pens that are pretty simple, and we have a long experience, of course, with diabetics, but it's still a lot easier to get people to use, pills.